A very good afternoon. So I'll be talking about artificial intelligence in retinoblastoma. I do not have any financial disclosures to make. Now, artificial intelligence in medicine is increasingly becoming popular more in areas of cardiology, radiology, pathology, etc. And it is mainly based on two parameters. One, the numerical data like the heart rate, respiratory rate, etc. Or it could be image based like the CT or the MRI images or pathology slide images. Now, in ophthalmology, it is very popular already for diabetic retinopathy, retinopathy of prematurity, and is somewhat being used in oncology. Now, if we look at ocular oncology, retinoblastoma is one of the most common cancer that we see in children, and more than 50% of the cases present with advanced disease because there is no routine fundus screening that is performed in newborns or later in childhood. Over the years, we have gathered a large image data bank of capturing fundus images of all children who present with retinoblastoma. So we thought, why not use these images to develop an AI model for diagnosis of retinoblastoma. So the purpose of this study is to explore the utility of artificial intelligence and machine learning for diagnosis of retinoblastoma, and if detected, whether we can develop a model to classify the intraocular retinoblastoma. So the method that was used were the RetCam images were extracted first and they were labeled manually by two experts, and these same images were fed into the machine, and using various algorithms an AI model was developed to identify retinoblastoma. So whenever such an image is fed into the computer, it should be able to identify as a normal fundus. If such an image is fed, then it should be able to identify that this is a group A tumor. If a larger tumor, then a group B tumor. If associated with localized seeds, then group C tumor. If associated with diffuse seeds, a group D tumor. And if it is an extensive tumor, a group E tumor. Multi-label classification model was used for identification of the optic disc and tumor by developing a bounding box with confidence interval, and the machine was taught that optic disc size is 1.5 millimeters, so the tumor size was compared to the optic disc size to measure the tumor, and whenever the optic disc was not visible, the machine was taught that the circle within which the tumor is present, it measures approximately 12 millimeters. The seeds were identified by using OpenCV algorithm to identify the potential region of interest, and once the potential region of interest is identified, a deep learning model is used to identify the subretinal and the vitreous seeds. So the AI model was ultimately trained to identify the optic disc, the tumor, the size of the tumor, the distance of the tumor from the disc, the presence or absence of seeds, and the distance of the seeds from the tumor. An image analysis was done on 771 images of 109 eyes, of which 78 harbored retinoblastoma, and there were 31 normal eyes. The manual analysis was done by two experts, and there was good agreement between the two experts. The inter-observer variability when it comes to individual images was less than 1%, but the cumulative classification when the inter-observer variability was 0%. That is, each eye had a minimum of 4 images and a maximum of 20 images. For example, if such an image is shown, then this would be called as normal, but if a different quadrant of the same eye is seen, there is a tumor with a seed, so it would be labeled as group C. Then if we go to a different quadrant, we see that there are more number of seeds, so this will be classified as group D. And in another quadrant, there is a larger tumor with diffuse seeds, so this would be a group D tumor. So the cumulative classification would be that this is a group D tumor. Using the AI model, the accuracy in detection of retinoblastoma was 95% and classification as per group was 85%. The missed diagnosis was noted in 3% cases, overclassification in 9%, underclassification in less than 1%, and misclassification of normal as retinoblastoma in 2% cases. So overall, the sensitivity and specificity for detection of retinoblastoma was more than 94%. The specificity was more than 90% for all the groups, while the sensitivity ranged between 63 to 100%. So in conclusion, AI model is a promising tool in diagnosis of retinoblastoma, and it may be useful in classification of intraocular retinoblastoma. The strengths of this study is that this is the first AI model for RB. It can serve as a useful retinoblastoma screening tool, and it has very high sensitivity and specificity for detecting normal versus retinoblastoma. Of course, it has limitations, like this AI tool was developed by feeding only the normal and the retinoblastoma images. We did not feed the other pathology into the system, so we are yet to do that. The sensitivity ranged between 63 to 100%, and there was unequal distribution of images in each group. The future plan is to increase the sample size and use other machine learning models to improve accuracy. The ultimate goal is that we should be able to screen the fundus images and identify which are the normal eyes and which require referral. For example, if this image comes, it should be termed that this is a normal eye, and if such an image comes, it should be identified that this eye has retinoblastoma and should be referred immediately. Thank you very much.
Thank you, Dr. Swathi. Very nice study. Can I request Dr. Kasturi to make a comment?
Very beautiful study, Swati. Very nice. I have a question. You have mentioned about the image-based data. So what is the algorithm that you have taken for every patient?
So every patient, the fundus photos were fed into the computer, and they were mainly the computer algorithms that were used. It was the OpenCV algorithm, which was mainly used in most of for most of the parameters, and deep learning model. These were the two parameters these were the two algorithms that were used to identify the various parameters for a fundus photo. So the parameters that were studied, as I elaborated, were presence of the optic disc, the tumor, yes or no, then seeds, yes or no, and what is the distance, what is the size of the tumor. So these were all the parameters that were studied.
And you mentioned it's a very nice screening tool. So will it accept only the RETCAM images or image of any iPhone or many other device that I see people using it?
Yeah, thank you. I think that's a wonderful question. So we are right now looking at various parameters, whether the different machine captured fundus photos, what is the difference in identification, the different races as well, like Caucasian versus Indian race, if there is any difference in identification of the tumor and other parameters. So all these are ongoing studies, and we are also working on developing a low-cost, non-mydriatic camera to see that if we can provide a low-cost, a model to capture the images and then use those images and see if it can serve as a screening tool.
What is the possibility of a false positivity?
So as I showed that there were few cases, like there were 2 cases where it was normal, but it identified as that there was retinoblastoma. And when we went back and saw why there was so, it was mainly because of the artifacts that were there in the picture. So false positives is a possibility, but it was in 2% of the cases.
The reason I raised this question, because the diagnosis has implications.
Yes.
If you're going to use it as a screening tool and a false positivity comes, and that is going to have a lot of implications in terms of, again, re-examining and confirming the diagnosis.
Completely agree.
Extension of that question. Actually, we did a similar study on using AI for detecting infectious keratitis. So we had a hell of a problem teaching the algorithm the difference between an active infiltrate and a scar. Because anything with so much size and of that particular color, it would detect as an infiltrate. Correct. So we had to do multiple retraining of that particular model to somehow, identify an infection from a scar. And as we speak, this article is in press in the IGO. So as an extension of Madam's question, anything on the retina or in the vitreous cavity, for example, uveitis or a CRA patch from a 2-dimensional picture, it will compare it with those pictures which you fed it and diagnose it as, retinoblastoma.
That will be the major.
So the point that I'm trying to make is maybe in pediatric populations, these general diseases will be less.
Yes.
Okay. But if a few of them are there, then false positives is what you may really be worried about rather than false negatives, as an extension of what Madam tried to point out.
Completely.
This is what I thought was very important. Confounding pathologies would be the major test of the screening device.
Yeah, we had that problem even in corneal ulcers, from scar to ulcer, it could not differentiate very easily.
Yeah, completely.
Just regarding methodology, 3 questions. One is, you have a data imbalance.
Correct.
You have more of, very less about 31 normal. How you handled that for the deep learning? Because you don't have, the numbers are different. What you did for that.
Correct. And even that's why I put it in the limitations as well, because if we see the distribution in group A, B, C, D and E, there is a disparity. There were more number of...
handled to get the AUCs, you must have handled by some way. You generated more images, what was the way?
Yes, correct. Yeah, so using those same images itself, more images were generated to train the model. And that's how we, right now we have, actually this data that I presented was the initial data. We have worked further after that, like we have almost doubled the numbers, and we have worked further on that to correct that imbalance. So that we will be publishing soon. Thank you.